Welcome to KMET 1490 AM ABC News Radio and the Southern California Business Report with Yvette Walker, a show dedicated to highlighting successful Southern California businesses and the people behind them.
Welcome and thank you for joining Southern California Business Report on ABC News and Talks, KMET 1490 AM, 98.1 FM, and KMET TV. I'm Yvette Walker, live blasting our signal from the center of Southern California, serving a population of over 25 million. Get us crystal clear and on demand by downloading the free live streaming app on Google Play and the Apple App Store. As always, a huge shout out to the team, Mitch, Bill, and Sean. I love you guys. And to our special advisory committee that can be found at www.scbrtalk.com/advisory committee. Today, I have the distinct honor to introduce Megan Barajas and John Chapman. Megan Barajas is the Inland Empire Regional Vice President for the Hospital Association of Southern California, also known as HASC. HASC is a nonprofit 501c6 regional trade state association dedicated to effectively advancing the interests of hospitals in Los Angeles, Orange, Riverside, San Bernardino, Santa Barbara, and Ventura counties. Megan's focus is on public policy and advocacy for hospitals in the Inland Empire, supporting 36 general acute care hospitals, 3 long-term acute care hospitals, 4 acute psychiatric hospitals, and 4 rehabilitation hospitals. John Chapman is the President and Chief Executive Officer at San Antonio Regional Hospital, also known as SARH, in Upland, California. Mr. Chapman joined the hospital in 2018 and is currently serving as the 7th president and CEO in the history of the hospital. San Antonio Regional Hospital has 363 beds, a staff of over 500 physicians, 2,000 employees, and 300 volunteers. The hospital offers advanced patient care throughout the Inland Empire. John also currently serves as the CEO chair for the Hospital Association of Southern California, as well as serving on the board of directors as second chair for the Inland Empire Economic Partnership. In his 4 years at the helm of San Antonio Regional Hospital, John has ushered a financial turnaround that has seen the bond rating agencies improve the ratings of the hospital each year during a time when the hospital industry in general had a negative outlook. San Antonio has continued to grow their programs and staff, achieve numerous national awards, including the only hospital in our area with a 4-star Medicare ranking. At San Antonio Regional Hospital Medical Group, with multiple sites to increase providers for our community, open new urgent cares, and most recently purchasing a 185,000 square foot building in Rancho Cucamonga to serve as a center of aging, a one-stop shop for all senior clinical needs. Oh my goodness. Thank you both so much for being with us here today.
Thank you, Yvette, for inviting us.
All right, Megan. Well, you are new to the program. You're a new guest, so I will start with you first. As you know, one of my first questions that I ask every one of my guests is to please walk us through your journey. What inspired you to pursue a career in the medical field, or in the healthcare field, so to speak, and now becoming the vice president, the regional vice president for HASC?
Yeah, thank you, Yvette. Thanks for having me, and it's a pleasure to be here and to share a bit about myself and updates from the hospital field. So my journey to this role is very unique. I started with HASC almost 9 years ago now as an administrative assistant, which had been my area of expertise for a long time. But I knew that I could do more, and I wanted to do more, but I also knew that I needed an education. I needed at least a bachelor's degree if I wanted that growth. So I went to school. I worked full-time and was a single mom at the time. So I'm very grateful for an online program where I could do school, late at night and in my pajamas. And then when I got my degree, my predecessor, the previous RVP, he said he was thinking about retiring in the next few years, and perhaps I could shadow him and start taking on more responsibilities and see if it's really a role that I would be interested in pursuing. And I said, no way. I said, I know how difficult your job is because I coordinate your calendar every day. But I gave it more thought, and I decided that if I was going to do his job one day, I needed more of a solid foundation in public administration and healthcare policy. And so I went back to school and got my master's degree. And about halfway through that program, the pandemic hit us. And so my boss decided that it was the right time for him to retire. And I said, absolutely not. You promised that I could shadow you for a while, and I can't do this, on my own. And he said, yes, you can. I believe in you. So there I was, filling in as interim regional VP during the most critical time in healthcare care during the pandemic, when our hospitals were unbelievably over capacity for months, which turned into years. And never in my life had I felt as insecure and as self-doubting as I did during that time. Trying to ensure that our hospitals in the Inland Empire were connected to the right people, the right agencies, to get the right resources and support they needed at times when there were no resources. And I know John can tell you that, they had to do the best that they could with what they had. So a few months into being the stand-in, our HASC leadership decided to recruit for a permanent regional VP. And some of my colleagues here at HASC asked if I was going to apply. And I thought, well, I'm doing the job now. I mean, how much harder could it get, right? So in the middle of the pandemic, supporting our hospitals, I applied, and I doubted myself the whole time. Of course, while still doing the job. And I told our Chief Operating Officer, Mark Gamble, I said, I don't think I could do this. And he said, yes, you can. I believe in you. And so here I am today. I figured out that it's not easy by any means. I had to go from an administrative assistant to regional vice president literally overnight. And I guess the timing and circumstances really played a big part in propelling me into this role. But if I had not gone back to school to get that foundation, then I'm not sure that I would have lasted. And I'm still trying to figure it out. But I do have a deep appreciation and empathy for our hospitals. They are truly the pillars in our communities, and their stories are more complex than most people realize. And so that inspires me to do what I do every day, because at the end of the day, I'm a patient too.
Absolutely. Yes, we're all patients at the end of the day, one way or another. And thank you for that. John, please, same question to you. Please talk about what inspired you to pursue the healthcare field and now becoming the 7th president and CEO of San Antonio Regional Hospital.
Well, it was a path I wasn't looking for, but it turned out this way. I graduated from UC Berkeley with a degree in microbiology and immunology. And I'm like, what am I going to do with this? And I had found out that there are clinical lab scientist roles specific for clinical microbiology in hospitals. I joined at University of California, San Francisco Medical Center. And, God was gracious. Within 2 years, I was their manager. Within another 2 years, I was the lab director. And the chair there paid for my master's and my MBA. Was recognized, luckily, ran service lines, helped open up the Mission Bay campus in San Francisco. And then that same chair says, you've been at UCSF for 15 years. What are you still doing there? And they offered me the chief operating officer job at Highland Hospital Trauma One Center in Oakland. But what I didn't know is they were going to give me all the ambulatory clinics in Alameda County, which is one of the largest counties in California. So trial by fire. I guess I passed, and was recruited probably 5 years later to San Antonio Regional Hospital with the idea of first serving as COO and then transitioning into the CEO role. And I've been the CEO since 2019.
Tremendous. Thank you so much for that. Okay, Megan, please talk a little bit about HASC's history and their mission for their stakeholders.
Yes, thank you. So HASC was founded 100 years ago, which is hard to believe. But as you mentioned, we are a nonprofit 501c6 regional trade association, and we cover a 6-county region. So we do not only Riverside and San Bernardino counties, but LA, Orange, and then further north, Santa Barbara and Ventura. And we have over 180 member hospitals and over 30 health systems in our region, in our HASC region. And we also have a list of professional associations and associate members. And we work in partnership with the California Hospital Association, or CHA, and we collectively provide leadership at the local, state, and federal levels on legislation, budget concerns, regulatory issues. But locally, HASC works with county board of supervisors or city councils, chambers of commerce, our public health departments, our behavioral health departments, and other key stakeholders to ensure that our hospitals' voices are heard. And so our overall mission is to lead and represent and serve our hospitals and work collaboratively with those stakeholders to improve the health and healthcare in the communities that we serve. Specific to the Inland Empire, as you said, I support 46 hospitals. That is 36 general acute care facilities, 3 long-term acute care hospitals, 4 acute psychiatric hospitals, and 4 rehabilitation hospitals. And in my capacity as regional vice president, I work closely with all of our hospital executives like John to help identify challenges or opportunities as it relates to advancing policies and system solutions.
Oh, that's a lot. That is a lot under your purview and under your umbrella. John, please talk about the value of being part of HASC from a hospital administration standpoint.
Besides getting to work with Megan, HASC is HASC, CHA, and the other 2 regional subsidiaries of CHA. The whole bit is advocacy, right? A hospital, we're a independent nonprofit. There's many times where we look for collaboration with hospitals in our region, or hospitals in Southern California, or even state legislation, right? I'm sure you'll hear a little bit about minimum wage for healthcare. I think we're going to talk about that a little bit later. The 2030 seismic compliance coming down, how our hospital is going to afford that. God knows there's a slew of bills that come out every few months. Some good for the hospitals, some where it was obvious the person who wrote it didn't quite understand how hospitals work. So it's nice having HASC and CHA in the background saying, we're going to oppose this. Here's the reason why. And they throw advocacy at the legislature to help change or guide them on the right path.
That's great. Okay, so Megan, please talk about what you do for your members and how you work together to solve some of these healthcare challenges that John just mentioned.
Yes. So, John, mentioned our number one focus is advocacy and representation on legislative issues and regulatory matters. And so we help try to influence those policies, guide the legislators, as John said. We also provide educational programs and trainings for our healthcare professionals to help them stay updated on industry trends and best practices and stay in compliance as well. We provide networking opportunities for our members to connect and share insights. We assist in emergency preparedness, as I did with the pandemic, but also through an emergency communication network called ReadyNet, which is a system that hospitals and first responders use, and ReadyNet is a subsidiary of ours. We also offer quality improvement resources. We provide access to a variety of communication resources, such as newsletters and reports and updates on issues that are relevant to our region. And we collaborate with our facilities and facilitate those stakeholder conversations with our members.
Beautiful. John, okay, with everything that Megan said, please talk about, some of the bills or policies that you're keeping an eye on as they're coming down the pipeline, and of course, talking about why it's important to do so. It's for obvious reasons, but please tell us your perspective.
Yeah, sure. I'll give you 2. One near and dear to my heart is AB 977. It's basically workman's comp legislation right now is saying, can you believe this? If there's violence on an emergency care worker in the ED, half the time they get off with misdemeanors, they're picked up. I actually had someone who slashed a physician with one of those linoleum knives and wasn't even arrested. That's just unheard of. How do you feel safe in an ED? My story is one of probably hundreds. All you have to do is go on any of the news channels and you hear about something happening at a hospital, whether it be gun violence, threats, etc. So AB 977 would extend the penalties for violence committed against first responders to all healthcare workers who provide services within emergency departments. So that's one we're definitely behind Rodriguez out of Pomona, who's supporting this, and HASC is supporting this effort. The other one, which didn't make any sense to me when I saw it, and this is when I was talking about workman's comp, is they say if you're an employee at a hospital and you get cancer or PTSD or a musculoskeletal injury, any respiratory disease, guess what? You caught it at the hospital. Does that make any sense? My whole family had COVID over I don't know how many times in the last year or two. I'm a microbiologist. We're probably safer at the hospital with some of the masks and infection control prevention that we do. But that's just putting the burden, the cost on hospitals where it really doesn't make sense. So AB 1316 would create a rebuttable presumption in this worker compensation system that these types of illnesses or disease arose out of work for any hospital direct patient care worker. So we're against that. Obviously, CHA and HASC are sponsors to have this turned around. So those are two recent examples to give you.
Wow, those are huge updates and big bills to keep an eye on.
Absolutely.
Megan, please talk about the recent changes in the emergency medical system with the change in ambulance carriers, in this case, AMR to Confire, which everybody in Southern California, you look around, the ambulance providers are, for the most part, AMR.
Yes. So Confire was recently selected as the new ambulance provider for San Bernardino County for specific areas. So not the whole county, but for specific areas. And it was through a request for proposal or RFP process. The current provider, who is AMR, American Medical Response, they and their predecessor companies have been providing this service to the county since the late 70s. And the county had not historically gone out to RFP to procure an ambulance provider through a competitive bid. So what they've been utilizing instead is a grandfathered process. However, in the last couple of years, the county and the EMS agency, or ISEMA, they recognized that the procurement process was an opportunity to move the entire EMS system and the 911 ambulance services away from the traditional mindset of responding simply to calls for services and really making it a new paradigm of providing the right resources to the right patient and at the right time. And so in light of that necessity that the county decided, they released an RFP. Confire's proposal received overwhelming support, not only from our hospitals, but from law enforcement, from labor, other private ambulance companies, and ultimately the County Board of Supervisors, who made the decision to select Confire. And Confire, it stands for Consolidated Fire Agencies, and it's a joint powers authority, so a public-private partnership. And they are truly a leading innovator, having introduced the county's first emergency communications nurse system, or ECNS for short. And during the pandemic, it was utilized to help reduce some of the 911 callers that really weren't at that high acuity level that needed transport. And so this also helped with our ambulance patient offload delay, or APOD issue, and I'll go over that in a moment.
Sure. So, John, please talk about how this change will benefit patients and hospitals and employees of AMR and Confire moving forward with this big dramatic change?
I was the hospital representative that Confire picked when they were setting up their bid. And it was obvious to me, and obvious after we communicated with other hospital leaders, including HASC, that they understood what hospitals were going through. They included hospital leadership, myself and others, to give feedback of what was needed for a bid that would benefit hospitals. And I'll give you an example. They understood that there's a back end to a hospital. So when a hospital has issues, when they see ambulances lined up, instead of penalizing or having conflict with the hospitals, which historically had been the case, Confire knows that we have to invest just as much in the back end transport, getting patients out of the hospital that don't need to be there, to get the throughput of patients from the ED to the inpatient bed to discharge out. And they'll get their flow, you'll have better APOD times. And even after getting this bid awarded by the supervisors, within a week, they called our HASC CEO meeting that I chaired and said, we want bi-weekly meetings as we move forward with hospital leadership. So they're invested. Secondly, even healthcare workers get sick during pandemics. What's nice about Confire is the fire department has their own group on call, in addition to the ambulance service who they're partnering with. So the ability to backfill when times are tough or employees are in high demand or lack of because of a, God forbid, another COVID large outbreak, they have more resources to throw at it. So very happy with the selection.
Very good. So Megan, we're talking about APOD now. Please explain what it means and how it impacts patient care.
Yes. So APOD is an acronym for Ambulance Patient Offload Delay. And as John was saying, it's an incredibly complex issue. And there are many factors that contribute to APOD. And they've played really the entire healthcare delivery system for decades now. So APOD is not a new thing. It's been something that we've all had to deal with for a long time now. And so really delays are a symptom of a broader issue. And many of those issues are beyond any one entity's control. Our emergency rooms are severely overcrowded. We've seen an increase in emergency room utilization for non-emergency conditions, as well as increases in chronic conditions that become acute conditions because of the lack of preventive care measures and patients being able to see their primary care physician. So not only that, but there's an increase in the use of emergency rooms for behavioral health crises, which I know that we'll talk about here shortly. But the throughput challenges, they are compounded by the hospital's inability to move those patients to lower levels of care. And that is largely attributed to the fact that we don't have the capacity outside of the hospital to transfer those patients to. And that includes psychiatric facilities, skilled nursing facilities, even housing for those with social needs like homelessness, not having a safe discharge destination after they are medically cleared. And so there are a lot of different things that contribute to long lengths of stay, and they are not, it's not the hospital's fault. I will add that, John, I don't know if you've been asked this question, but I've been asked, why don't hospitals just hire more staff to speed up ambulance offload times? And unfortunately, it's not that simple. An increase in staff, if you can find them in the first place, does not increase space in a hospital, nor does it increase the capacity that I was talking about in the community to transfer to those lower levels of care. So it's incredibly difficult to decompress our hospitals and get that throughput flowing efficiently. And hospitals really have to get creative in using their space. within that regulatory compliance with state licensing. And there are mandates like nurse-to-patient ratios that hospitals must comply with. And like John said, there's patients walking in the front door, we have ambulances coming in through the back door, and hospitals can't turn anyone away. So it's really, the sheer inundation at times that makes it very difficult to manage the volume of patients.
Thank you so much for that, Megan. Okay, we're coming up on a break, everybody. Yvette Walker with ABC News and Talk, Southern California Business Report, here today with John Chapman and Megan Barajas, both healthcare industry leaders with extensive experience and remarkable achievements instrumental in transforming the healthcare landscape in Southern California. Both tirelessly advocate for healthcare policies that benefit patients and healthcare professionals throughout California. When we return.
The University of La Verne is rated first in California for alumni satisfaction. Learn more about accelerated programs offered online and on campus in La Verne, Irvine, Ontario, Burbank, or College of the Canyons. Visit go.laverne.edu. The University of La Verne. go.laverne.edu.
We are the Empire Strikers, the professional sports team of the Inland Empire. We are a fast-actioned and community-inspired pro indoor soccer team. Our mission is to inspire the Empire. Home games, community events, watch parties, and youth camps are all back. Professional indoor soccer is back. Join us and come watch the greatest show on turf at Toyota Arena or on Twitch. Visit www.theempirestrikers.com for more and any information.
Hi, I'm Dana Rademacher with MGR Property Management.
A lot of people wonder about the value that property management has for their property. Property management can include all property types, including residential, commercial, and HOA. It is valuable because property managers are experienced in what can happen at your property. We're aware of liabilities. We're able to do predictive and preventative maintenance. We know what is coming up with the changes in the weather, the seasons, how old certain aspects or different capital projects at your property are. We're able to best negotiate contract pricing, legalities with your tenants, and anything else that you may need to ensure that you're getting the full value of your property. If you're interested in speaking with the representative at MGR Property Management regarding your property management needs, you can visit our website at mgrrealestate.com, or you can call our number at area code 909-581-6600 to be connected with a representative.
Hi, I'm San Bernardino County Sheriff Shannon Dykes. If you're looking to start an exciting career in law enforcement and make a difference in your community, we are hiring dispatchers, nurses, deputies, laterals, and many more. For a complete list of our jobs and more information, visit sheriffsjobs.com.
Ontario International Airport is on to a better way to fly with over 65 daily non-stop flights to more than 20 major destinations and the easiest airport experience in Southern California. Visit flyonto.com/Ontario to learn more about Ontario International Airport today.
Welcome back, everyone. Yvette Walker with ABC News and Talk, Southern California Business Report, here today with John Chapman, CEO and President of San Antonio Regional Hospital, and Megan Barajas, Executive Vice President of HASC, two healthcare industry leaders with extensive experience and remarkable achievements instrumental in transforming the healthcare landscape in Southern California. Both tirelessly advocate for healthcare policies that benefit patients and healthcare professionals throughout California. Thank you both again so much for being with us here today.
Thanks, Yvette.
All right, so prior to the break, we heard from you, Megan, on what HASC is, how it serves patients and hospitals, and what that dynamic between hospitals looks like. John, please talk about innovative solutions you are applying to address the emergency department flow in conjunction with APOD, which was the acronym that Megan shared with us earlier.
Sure. So, as Megan has said, it's complex, but I'll share a few solutions that San Antonio came up with. Megan had talked about the type of patients who go for emergency care. I'd say in our hospital, 30%, at least 30% of the patients who show up in the emergency room really did not need emergency room level of care. Where could they have been treated? They could have been treated at any one of our 5 urgent cares for San Antonio. Probably be a lot less wait time and probably a very better outcome in terms of getting home on time to have dinner. So what we do is we actually keep track of the number of patients who come. They're called frequent utilizers. And there's 5 different levels in hospitals. Levels 1 to 3, you belong there in the emergency room. Level 4s and 5s, those are your sniffles, your sore throats, your colds, not your chest pain patients. Those individuals, we actually give marketing brochures, and we actually have case managers who call up, especially if they've been to the emergency room multiple times, to say, hey, 5 minutes from your house is Milliken Avenue, and we have an urgent care there that's open 7 days a week. So that's one way to kind of make it easier and less patients coming into the ED. The other thing Megan had said is, you may have heard, there's such a dearth of primary care physicians that those who are getting discharged from the hospital aren't seeing their physician within the 1 to 7 days they should be after getting discharged. So what happens? Something happens. They're usually the highest levels to get readmitted into the hospital because they didn't follow through. Perhaps they didn't understand the medication they were supposed to take. Perhaps there was something just as simple as another medication because of a complexity a day after coming out of surgery, for instance, that they didn't have. So what we've done at San Antonio, we have what's called our Care for You clinic, and we schedule everybody that we consider medium to high risk, even if they have a primary care physician elsewhere, to come to our clinic within 3 days. And what we've noticed is those that don't come to the clinic, 36% of the time, there's readmissions. Those that do, we've got it down to 13%. So we're hoping that type of solution expands out with our collaboration and sharing of knowledge with our other hospital entities. Third thing we do that many patients, especially senior patients or those who don't have loved ones, maybe they live alone, they get discharged from the hospital and they're given a script. Go get your medications. Do they have a ride? Do they know how to get there? Can they get there? Do they forget about it? Do they understand how they're supposed to take the medications? Well, what we've done is we're giving up to 3 weeks of medications to every patient being discharged from our hospital. Again, in a mechanism to prevent them coming back as a readmission. 2 other items that really delay the back end of patients getting out of the hospital is many patients need oxygen, durable medical equipment, wheelchairs, you name it. Typically, setting that up could take anywhere from 1 to 3 days. We have a stockyard here. We invest and partner with a DME vendor. We give the DME equipment out the same day as their discharge. So that helps us not have as many patients in the back end waiting to be discharged. That impacts the front end, our ED, right? And then finally, we said the heck with it. At one time, we were so tired of not having transport for people home at 6, 7, 8 p.m. From the current transport agencies. We bought our own rig, and that starts up next week. Well, we figure we'll be taking 7 to 9 patients out of the ED or in the inpatient beds home on the night they should be going home. So these are I consider short-term solutions, but they work for San Antonio, and we're hoping that they work for some of our other hospital entities.
Wow, that is tremendous. I mean, you basically are unlocking the solutions to what you see every day. And I just have to say, because And I'm not just saying this because I've been a patient of San Antonio Hospital for over 20 years and I've taken all three of my children there, including myself at one point or another. But, we were just there maybe not even 2 weeks ago with one of my grown children in the emergency department. And something that I observed, although it was a very scary time for us, we observed a lot of people in pain, a lot of people that were patiently, arduously waiting for their turn to be seen. But another thing that I noted was the staff, the level of compassion, the cheer and the joy that they greeted each patient with, reassuring them that they would get the care that they needed in the time that they could get it to them. And to me, that showed, and I observed again, just an overwhelming sense of respect for the healthcare providers that were treating the patients in the lobby. And like you said, the lobby was full. It was full. Every seat was taken, but everyone was very calm. Everyone was very appreciative, and everyone was very patient to be seen in their turn. And I don't know how you do it. I don't know what you tell your employees and your staff, but everyone there was stepping in with joy, compassion, like a completely well-oiled machine. And I was just left completely impressed. And so my hat's off to you, and thank you again for treating my family as we always expect to be treated, with compassion and care and diligence. And I'm so thankful that you're continuing to evolve and address these issues for patients to deliver even better care. Because quite frankly, I could think of no better care than what we received on that day. So thank you for that.
Well, thank you for that testimonial.
Certainly. And so, Megan, behavioral health is a hot topic. Please talk about what resources are available versus what is needed. How do we implement more behavioral health resources?
Yeah, so almost a quarter of adults with mental illnesses in California are not able to receive the treatment that they need to prevent a crisis. And so right now, California has a shortfall of about 8,000 inpatient psychiatric beds for individuals with acute behavioral health needs. And because of this, hospital emergency rooms are the primary places to go when a person is experiencing a crisis. And there's no alternative to that. It is estimated that about 800 patients in California remain in our general acute care hospitals on any given day, despite being medically ready to leave the hospital. There's just nowhere to transfer them to. So our hospitals tend to be overrun. Those patients tend to stay in the emergency rooms for really long lengths of stay. And our patients tend to be transferred out of county, which also strains the resources for those counties. And we've been able to use peer supports and telehealth, but the demand for behavioral health services really has it outweighs the resources that we have. So the goal is preventive care. And the state recently invested billions of dollars in developing some comprehensive services with a focus on prevention, early intervention, and community-based care to help avoid those hospitalizations and incarceration, and even conservatorships. And right now is a good opportunity for me to put in a plug for Prop 1. We need all of Californians to support Prop 1 in the March primary to expand access for those dollars that were invested. So vote yes on Prop 1.
Got it. You have my vote. John, please talk about what is on the horizon for addressing behavioral health issues, and are there promising models to address the growing need?
Why'd you give me the hard question? We're trying to solve that statewide. Megan said it right. Proposition 1, let me talk a little bit more about that. Obviously, what you're hearing, if you're having telehealth in your hospital, that means we don't even have psychiatrists to be on hospital staffs. So how are you going to find the workforce to take care of not only acute, but chronic behavioral health and addiction issues if they're not here? So investment in the workforce those individuals who are in medical schools, expanding medical schools, getting them invested in family medicine, getting them invested in behavioral health is a long-term goal for the workforce. What may help us immediately, or once Megan gets Proposition 1 passed, is Proposition 1 it offers up to $6.38 billion in bonds to build new behavioral health housing and treatment settings. And it opens the doors for hospitals to collaborate on solutions. Right now, every county has their own behavioral health department, right? But sometimes they're only one entity. Hospitals are willing to step up, collaborate, and try to help find solutions. They need the dollars to do so, though, because it's difficult to do so without the workforce and the funds to build new acute and subacute psychiatric facilities. So Proposition 1's huge. Some of the items out there, I'll mention one that I think 13 or 14 states are using through a CMS demonstration. It's called Certified Community Behavioral Health Clinics. I'm not saying this is the end all to be all, but it's an example that seems to be working in some states where hospitals do come together or they collaborate with other entities that are there. And just like my Center of Aging, it's a one-stop shop for behavioral health and addiction medicine. So it has an acute wing, it has a chronic wing, it has an addiction wing, and there's certain guidelines, of course, that CMS says we have to live by. People are afraid of that right now because you've got to have the workforce to run something that's all inclusive. But what makes it fun is you can collaborate with multiple entities and vendors. It's just not one hospital running it. It could be a hospital with an addiction medicine clinic that's down the street, etc. So that's something that we're looking into currently in San Bernardino to see if there's any takers to try this type of solution.
Right. So, John, are there grants or other funding opportunities available to cultivate behavioral health services?
Well, Proposition 1's the big one. There's supposed to be dollars being given now where you hear there's going to be taxation on the Medicare intermediaries, right? Those who aren't straight Medi-Cal, but they're taking care of our seniors. That tax is supposed to go to behavioral health as well. And maybe I'll go to Megan and say, have you heard anything on the county side in San Bernardino or Riverside for additional funding?
Yeah, so we're looking into that. I'm not sure what that'll look like. And I know that Prop 1 will open up those different categories and buckets of where, those monies will flow through. But we, HASC, we work closely with our county departments of behavioral health in the Inland Empire, and we set out through our affiliate organization, Communities Lifting Communities, to secure a 2-year grant to do a more focused look in sort of a journey to understand, the nuanced challenges that our hospitals face relating to patients who present to the emergency rooms on involuntary holds because they tend to stay there for really long times. And so we're hoping that we can help improve the efficiency of those patients moving through the system and reduce those lengths of stay. So we've done the first year, we've completed all of our analysis and fishboning, and so our second year is our implementation phase and see what kind of best practices we can implement, and that'll work very nicely with the funding that will be coming down to the hospitals through Prop 1.
And so, Megan, what are you hearing from your stakeholders as the most looming challenges that hospitals are facing today?
Yeah, so sadly, our hospitals are still dealing with the financial impacts of the pandemic. Since the beginning of the pandemic, our hospitals collectively lost $20 billion. They only received $12 billion in federal relief, and they received $0 from the state. So there's an ever-growing gap between hospital revenue and expenses. And according to a report by Kaufman Hall last year, 1 in 5 hospitals in California is on the brink of closure. And so this study showed that the total expenses in 2022 were about $23 billion higher than pre-pandemic levels. And a lot of that is inflation of medical supplies and pharmaceuticals as well. And so John talked about reimbursement just briefly, but aside from the rising costs of care, and speaking about California in general, not just the IE, but our hospitals deal with inadequate payment from really all health insurance plans, but particularly the government payers. They reimburse below the actual cost to provide care, and this is because the state has not increased that reimbursement rate in over a decade to help keep up with the changes. So for Medicare and Medicaid, the government payer programs, which in California, Medicaid is called Medi-Cal. A quarter of our Californians receive this free or low-cost health insurance, a quarter. And so combined, Medi-Cal and Medicare reimburses our hospitals and other providers 75 cents on the dollar, which leaves an incredible gap of unfunded care. And yet 70% of our hospital volume is made up of patients with Medi-Cal or Medicare. And unlike our restaurants and retailers, our hospitals operate in this unique situation with fixed revenue because of those reimbursement rates not moving in the last decade. And so our hospitals have to do the best that they can with those cost pressures, and it creates a very scary financial situation. And, without solutions, the cost of care will become more expensive and even less accessible than it is now. Another challenge, I can go on and on about challenges, but I do want to highlight seismic as another looming challenge. There's a 2030 deadline to ensure that our hospitals are fully operational following a devastating earthquake. So right now our hospitals met a 2020 deadline to ensure that they'll remain standing. So they're among the safest buildings in California, but to remain fully operational will cost our hospitals $100 billion, which is another unfunded mandate. So there's no financial support for our hospitals to do this. And our hospitals already devote an extensive amount of time and money and resources into planning and training their staff to ensure that critical care is uninterrupted when a disaster like an earthquake happens. And frankly, if the pandemic taught us anything, it's that our hospitals can provide care without the four walls of a building. So our team at California Hospital Association at the state level is looking at that and see how we can advocate for relief. I just don't know what that looks like yet. And then another challenge that I wanted to highlight is workforce. We hear it all the time. There's a severe workforce shortage of healthcare providers, and so the pandemic delayed education and training for new healthcare workers, and it really slowed down that pipeline that was already insufficient to begin with. And so, our hospitals are investing themselves into providing that training, but unfortunately we can't grow them overnight. So we're just not able to train up the workforce fast enough.
Okay, so we're coming up to the end of the hour, and John, I'm going to ask you, as chairman of HASC, please share some insight and goals you intend on working towards in 2024 as president and CEO of San Antonio Regional Hospital and chairman of Hospital Association of Southern California. Sure.
We've already talked about behavioral health, but I'll augment what Megan's talking about workforce and what we're doing here at San Antonio, and I'm sure other hospitals are doing the same in San Bernardino and Riverside, and that's developing workforce pipelines. So if you're dealing with the University of Laverne, you're dealing with a 4-year college, even if you're dealing with a junior college, it's not just nurses that are in high demand, it's everybody. So what's the best of both worlds? Train people here inform them of the healthcare industry and the type of jobs that are available. And what we've done as an example with the University of La Verne, they said, we can't grow programs. I said, well, I'll tell you what, if you do OR technicians, I'll place 40 OR technicians in San Antonio. And they go, great, that means I could increase my class size by 40. This is what we have to do as an industry, partnering with the educational academics to grow their classes, whether it be at the junior college, or medical school levels. That's huge. And then finally, continued advocacy, right? 2030 seismic is coming up quickly. If that many hospitals are closing in California just on finances now, how in the heck are they going to afford this unmandated cost? So those three are huge, and we'll keep you informed of it.
All right. Well, you will both be back because we need these critical updates that impact us every day. I can't think of one person that's never been seen by a doctor or will never need medical attention. So thank you for your help. Thank you for your diligence. And we will see you again soon. All right, everybody listening today, don't forget to find us on Facebook, YouTube, LinkedIn, and Instagram. Check us out on scbrtalk.com. Don't miss my interview with Malik Mallory, a seasoned financial professional with a strong record of success in the industry. His journey began in 2017 when he started as an administrative assistant. Over the years, he diligently built his book of clients at his prior firm and subsequently took the bold step of starting his own firm, Mallory Wealth Management. Next week, we will have Dr. Raymond Wolf. He is the executive director of the San Bernardino County Transportation Authority. He joined SBCTA in April of 2012 after spending more than 20 years with the California Department of Transportation. At Caltrans, Dr. Wolf served in many capacities, including director for District 8, covering both San Bernardino and Riverside counties. He began his career as an aerospace engineer at General Dynamics Corporation. You do not want to miss it. We will see you all next week.